Hello everyone. In this class, we'll try to discuss about some of the case histories which are related to cardiovascular system and central nervous system. The first case is a young female comes with the complaints of drooping of eyelids and weakness of muscular movements during chewing, swallowing and speaking, especially in the evenings. On examination, there is the presence of ptosis and remarkable recovery was seen after injection of neostigmine intramuscularly. So the questions are here, what is your diagnosis? So here the diagnosis would be the myasthenia gravis, which is a neuromuscular junction disorder, autoimmune disorder where antibodies are formed against nicotinic receptors at the neuromuscular junction. And so that would be the cause for the myasthenia gravis. Okay. So because of the loss of nicotinic receptor, there will be gradual increase in the muscular weakness as the day progresses or uh, exercise increases. Okay. So there will be drooping of the eyelids, weakness of the muscular movements. There will be difficulty in chewing, swallowing. Okay. How does the neostin im- injection improve the condition? The neostigmine is a acetylcholine esterase inhibitor, okay, so which at the neuromuscular junction uh, will not allow the acetylcholine to be degraded once it attaches to the receptors and makes acetylcholine to act for a prolonged period over the receptors, and it improves the muscular contraction, and that is how it is going to improve the weakness. So there is another disease which is called as Lambert Eaton syndrome, which occurs, which is again antibody autoimmune disorder. There will be production of antibodies against voltage gated sodium channel. In myasthenia gravis, the antibodies are formed against the acetylcholine receptor, that is nicotinic receptors. Myasthenia gravis is related to the thymic tumor, whereas the Lambert-Eaton syndrome is associated with small cell lung cancer. In myasthenia gravis, here weakness worsens on prolonged exercise, whereas Lambert-Eaton syndrome, weakness improves on prolonged exercise because of the retention of the calcium in the presynaptic membrane. So repeated stimuli is going to increase the calcium inside the presynaptic membrane, and that improves the muscular contraction. In myasthenia gravis, the deep tendon reflexes are normal, whereas in Eaton-Lambert syndrome, it is decreased or absent. Myasthenia gravis will not be usually associated with autonomic dysfunction, where Lambert-Eaton syndrome, it is associated with autonomic dysfunction. Characteristically, in myasthenia gravis, on repeated nerve stimulation, there is a decremental response, whereas with the Lambert-Eaton syndrome, on repeated nerve stimulation, there is an incremental response that one should has to note. Then another case where a 60-year-old patient comes with severe constrictive pain behind the sternum on exertion, which radiates along the ulnar border of the left arm. X-ray of the chest was normal, that is the cardia was normal, and ECG shows a ST segment depression in lateral leads. The questions are, what is the diagnosis? Probably here the diagnosis would be the myocardial ischemia, which is a manifestation of a coronary artery disease. The reason why coronary ischemia is because the ECG shows ST segment depression. What is the cause for this disease? I mean, as I told, it is a coronary artery disease because of uh, the the occlusion of the coronary vessels. There will be reduced blood flow to the subendocardium of the myocardia. So that hypoxia will be seen as a ST segment depression in the ECG. And how do you treat this condition? Normally, the coronary artery occlusion, already myocardial perfusion is compromised. So you need to reduce the work done by the heart. So that is how you give vasodilator, so that like nitrates, so which can reduce the venous return by dilating the peripheral arteries and veins. Okay, so that is how that is going to decrease the venous return and improve the angina. But uh, the definitive treatment would be angiography and the stenting of the occluded vessels. So that will be a definitive treatment for the coronary artery disease. So, so this is a spectrum of coronary artery disease. So where myocardial ischemia is inadequate oxygen supply to the myocardium, and it's the most common cause of coronary artery disease, rather most common symptoms. And acute myocardial ischemia is evidenced by symptoms that is the angina pectoris, coronary, EKG changes, ECG changes, or there will be reduced dysfunction of the myocardial tissue. And the myocardial injuries uh, manifested with the elevated troponin levels above the laboratory upper reference limit because of the injury to the myocardium. Since there is an injury to the myocardium, troponin T or I is going to uh, increase, their levels in the blood are going to increase. Acute myocardial injury is a rise or a fall of the values with at least one of the above upper reference range. Okay, so that is how the myocardial injury is diagnosed depending on the troponin levels. And myocardial infarction is it is a combination of the both, that is myocardial ischemia and myocardial injury, where there will be irreversible damage to the myocardium. Okay, so that is how the acute myocardial infarction is nothing but acute myocardial ischemia with acute myocardial injury. And on the ECG, usually acute myocardial ischemia so will be uh, deflected in the ECG as ST depression. Okay, so J point is reduced, whereas acute myocardial infarction, that is with myocardial ischemia with the damage to the myocardium, so there will be ST depression with the reciprocal ST depression in the reciprocal limblets. Another case is an individual who was brought to the hospital from the site of an accident. He showed following signs and symptoms. There was restlessness, he was pale, there was a cold and clammy skin, rapid and thready pulse, hypotension, and oliguria. So the question is, what is the diagnosis? So probably because of the accident, the person has lost the blood. Okay, and it's a case of the hypovolemic shock, because there is a pale, cold, clammy skin and rapid thready pulse. Okay, so those are the signs of hypotension and shock. Okay, so that will be the diagnosis. The person is suffering from hypovolemic shock. So how do you explain the signs and symptoms here? Okay, so restlessness is mainly because of the hypoxia to the brain tissue. Uh, the paleness in the skin is because of the reduced amount of blood. The cold, clammy skin, it is because of the peripheral vasoconstriction. And rapid thready pulse, it is because of the loss of volume. And hypotension, obviously, there will be with reduced blood loss. And oliguria occurs because of the reduced renal perfusion. Okay, so that leads to decreased GFR and decreased urine output. Another case, a patient comes to a doctor with history of swelling of legs with which uh, swelling of the legs which increases towards evening. On examination, there was a dependent pitting edema, distension of the neck veins, enlargement of the liver, which was soft and tender. The jugular venous pressure was raised. On investigation, the chest X-ray showed right ventricular hypertrophy, and ECG there are prominent P waves and right axis deviation. In blood, nothing significant. So the diagnosis of this case would be probably the person is under right ventricular failure. So the person is uh, there is the decrease right ventricular output because of the right ventricular failure. So because of the right ventricular failure, the blood is being pushed into the systemic venular circulation where the pressure in the venular system has increased, and that is leading to the symptoms like pitting edema in the periphery, distended neck veins, enlargement of the liver, and uh, and the obvious jugular venous pressure. So the diagnosis of this case would be the right ventricular failure. How do you explain the dependent edema and enlargement of the liver? Okay, so as I told, so when the right ventricle fails to push the blood into the pulmonary artery, the back pressure in the right atria increases, then it is transferred to the venous system. Okay, so because of the increase in the hydrostatic pressure in the venous system, that leads to the limb edema, and the blood is going to be accumulated to the dependent parts. So when they are standing, so there will be a limb edema, and also there will be enlargement of the liver. Why P wave is prominent in ECG? So the prominent P wave in the ECG, it occurs mainly because of the enlargement of the atria. Okay. So the diagnosis of the right ventricular failure clinically, so which occurs because of the back pressure to the peripheral circulation, mainly depends on the presence of ankle edema, fatigue and wasting, the increased weight because of the edema, nausea, anorexia, and abdominal pain due to the hepatomegaly. Another case where a 65-year-old patient, a known coronary artery disease, comes to a doctor with a history of breathlessness on exertion. On examination, there were basal crepitations, uh, and on investigation, X-ray showed left ventricular hypertrophy. ECG showed old infarct, that the presence of the coronary artery disease, the previous coronary artery disease, and left axis deviation. That it is probably because of the cardiac ischemic cardiomyopathy, where there is a left ventricular enlargement. Blood, nothing significant. So the diagnosis here is the person is suffering from the left ventricular failure, probably because of the coronary arteries disease. So because of which the left ventricular failure, the blood is because of the back pressure, the blood is going to reach left atria and then to the peripheral pulmonary circulation. That is going to lead to the pulmonary edema. So that is why on examination there were basal crepitations. So this occurs mainly because of the pulmonary edema. So how do you explain the basal crepitations over the lung? As I have explained already, so the left ventricular failure, there is a failure of pumping of the blood to the aorta. So the back pressure to the left atria increases. From there, the pressure in the pulmonary vasculature is going to increase, and the increase in the hydrostatic pressure there is going to lead to the uh, pulmonary edema, which leads to basal crepitations. How do you treat the patient? So importantly, the patients are here, they are treated with the diuretics. Okay, so to reduce the extracellular fluid volume, that probably uh, uh, decreases uh, the entry of the fluid into the alveoli. Okay, and then obviously you have to give the substances or drugs which are going to increase cardiac pump activity. Okay. Then the left ventricular failure, which is the back pressure into the pulmonary system, usually they will be manifested with uh, dyspnea on exertion. There will be orthopnea where they will be having a difficulty in a lying down position, and there will be uh, no dyspnea on sitting down position. Okay, so that is called as orthopnea. Okay, so there will be reduced exercise tolerance. There will be nocturnal cough, probably because of the pulmonary edema. There can be wheeze, and there can be paroxysmal nocturnal dyspnea. Again, it is because of the pulmonary edema. Then lethargy, and the congestive cardiac failure is because of the failure of the both ventricles. Okay, so where there will be combination of the symptoms of right ventricular failure as well as uh, left ventricular failure. So these are some of the case histories of central nervous system, that is nerve muscle physiology, and the cardiovascular system. Thank you.